This morning, I'm happy to introduce one of our own chief residents, Dr. Ushma Patel. Dr. Patel is originally from the suburbs of Chicago. She completed a Bachelor's of Science in Biomedical Sciences at Marquette University and moved back to Chicago for her medical degree at Loyola University Stritch School of Medicine. In medical school, she graduated through the Global Health Honors Program and subsequently was selected to the Global Health track here at UW. She has matched in urogynecology and will be staying here at UW for fellowship. She hopes to continue to incorporate global health into her future career as a urogynecologist and has a special interest in fistula repair. Please join me in welcoming this morning, Dr. Patel.
Thank you, Dr. Pizzuto. Good morning, and thank you to the department for the opportunity to give this talk. It's a topic I've been passionate about for the last 8 years. I have no relevant disclosures. My objectives for this talk are to define what global surgery is by taking the scenic route and discussing the evolution of the topic and how the current situation came to be. Next, I'll examine this 3 delays framework surrounding accessibility of surgery worldwide. And finally, I'll focus on strategies to overcome the global surgical burden. Global health is one of the defining issues of the 21st century, and it's truly propelled health and disease from a biomedical process to a social, economic, political, and environmental concern. To paraphrase this definition of global health from the Lancet, I would say that at its most basic, global health is about achieving better health outcomes and eliminating health disparities for vulnerable populations, including individuals and communities, through a collaborative intervention. Now, my own grand rounds wouldn't be complete without some commentary on terminology. Classification schemes are convenient for analysis, but every single one comes with a set of limitations, biases, and cultural overtones. When we're talking about global health, the words listed on the left are terms we often hear. The first one doesn't really require too much explanation, and I'll get rid of it right off the bat. There's no third world or first world for that matter. There's one world where there was the oppressed and the oppressors and the resultant socioeconomic situations that occurred. So moving forward, we won't use that term. The next term, developing world, was used in the past, but now we're beginning to turn away from it. It paints a picture of Western societies as ideal and perpetuates stereotypes about people who come from the so-called developing world as backward or ignorant. The term also lumps together countries that have no similarities. For example, Malawi's gross national income per capita is $250, while Mexico's is $9,860. Similarly, estimates of extreme poverty rates vary from 3% in Mexico to over 70% in Malawi. So we'll get rid of that. Some people use the term majority world, a reminder that high-income countries are a very small minority on the globe, and 80% of humanity lives on $10 or less per day. The next term, global south, is terminology used to address countries negatively impacted by capitalist globalization. It conveys the role oppressors or colonizers had in resource deprivation. Unfortunately, majority world and global south both require further explanation to those who are not familiar with those terms. So maybe the solution is to use a classification based on economics. And that's how we categorize countries now. The World Bank groups economies into one of 4 categories: low income, low middle income, upper middle income, and high income. The categories are used to show how different groups of countries are doing against measures such as reducing poverty, growth, increasing income per capita, and so on. Labels will never be perfect, but classification by economics is what we'll use going forward. In an effort to combat poverty, hunger, disease, illiteracy, environmental degradation, and discrimination against women in a measurable way, the Millennium Development Goals were created. These were 8 goals with clear targets and deadlines for improving the lives of the world's population. Leaders of 189 countries signed the Millennium Declaration at the United Nations Millennium Summit in 2000. They proceeded to create the 8 goals listed here, with a target achievement date of 2015, which was just 15 years later. Unfortunately, these goals were not achieved by 2015, which I don't think is surprising to anyone in hindsight, but there have been significant gains in global health in the last 30 years, catapulted forward by these Millennium Development Goals. Members of the United Nations and global health leaders could already see by 2009 that the Millennium Development Goals weren't going to be achieved. So in June 2012, at the UN Conference on Sustainable Development, Rio 20, member states adopted an outcome document titled The Future We Want. They decided to launch a process to develop a set of goals that would build upon and accelerate the progress that was already started by the Millennium Development Goals. And in 2013, the General Assembly set up a 30-member group to develop a proposal on such goals. And in September 2015, at the UN Sustainable Development Summit held in New York, 193 countries unified for this 2030 Agenda for Sustainable Development, and these 17 Sustainable Development Goals were launched. The purpose of these goals was to stimulate action over 15 years towards a safe, resilient, and sustainable world with a focus on economic, social, and environmental development. The transition from the 8 Millennium Development Goals to 17 Sustainable Development Goals marks a shift in the international community's approach to development, away from a vertical disease-specific programs approach towards a horizontal intersectoral systems approach. A vertical approach is just what it sounds like, top-down. It's disease and cure focused. It isn't truly sustainable because it depends on continued outsider contribution and funding. The horizontal approach to healthcare contrasts this, and that is prevention focused. It takes the socioeconomic determinants of health into consideration, and efforts are community-led and sustainable. The Sustainable Development Goals emphasize the need to strengthen health systems by building service delivery capacity and ensuring sustainability, which is how they were named, and they're a horizontal approach to health. But the progress in global health hasn't been uniform. And what I mean by that is the triumph of the last 30 years has been eradication of infectious diseases, and even a slow improvement in global maternal and perinatal conditions. But now the burden of non-communicable diseases is overtaking that of infectious disease. You can see that deaths due to non-communicable diseases plus injuries equate to 70% of total deaths globally. And if we take a look into the management of disease from our perspective in a well-resourced health system, we know that the management of conditions is either expectant, medical, or surgical. This figure from the Global Burden of Disease study depicts the frequency of surgical management in a well-resourced health system for 2010. This is a breakdown by disease category for patients admitted to hospitals in a well-resourced health system. Although we conceptually understand the importance of surgery, this figure really hits home that surgery is a treatment modality that's needed regularly across the entire range of human disease. When we look even more specifically at maternal disorders, we see that procedures are utilized approximately 35% of the time. And further, you can start to see that not having surgery available threatens the overall progress in global health and threatens the 2030 Agenda for Sustainable Development. But we only started understanding this recently. In 1980, Dr. Halfdan Mahler, the then Director General of the World Health Organization, gave an address called Surgery and Health for All. He didn't have these statistics available, but he understood the importance of surgery in healthcare. He was the first one to highlight that the vast majority of the world's population had no access to surgical care. He was adamant that surgery had a major role in bringing the people of the world closer to the goal of health for all. Despite his address in the 80s, surgery in global health didn't get much traction. Surgical care was typically considered as too complex, too expensive, or as having too limited a role to play in treating the global disease burden. The reality is that there's a growing need for surgical care, but the development and delivery of surgical and anesthesia care in low and middle income countries had been nearly absent from the global health discourse. Little had been written about the human and economic effect of surgical conditions, the state of surgical care, or the potential strategies for scale up of surgical services in low and middle income countries. But finally, after years of inattention, surgery started gaining recognition as a legitimate component of global health. Initially, the WHO started the Global Initiative for Emergency and Essential Surgical Care in 2005 as a global forum that convenes multidisciplinary stakeholders to share knowledge, advise policy formation, and develop educational resources to reduce death and disability from surgical conditions. The next major point of recognition came with re-examination of the Millennium Development Goals. Re-examining the goals led to seeing crucial gaps in global surgical care and realizing that the need for surgical services will continue to rise substantially from now until 2030. To begin to address the gaps, the Lancet Commission on Global Surgery 2030 was launched. And at the first assembly, the president of the World Bank, Dr. Kim, reformatted the surgical landscape when he emphasized surgery is an indivisible, indispensable part of healthcare and can help millions of people lead healthier, more productive lives. Fortunately, his words landed on fertile ground as numerous individuals and groups in global health had begun embracing the role of surgery as a vital resource in global health. It was especially exciting to see the Disease Control Priorities Organization, a multi-year project funded by the Bill and Melinda Gates Foundation, release a book titled Essential Surgery, which highlighted surgery's role in global health. Defining a place for surgery in the current global health paradigm of disease-based care and issue-specific advocacy was challenging. But finally, global surgery gained momentum, and thanks to the Lancet Commission on Global Surgery 2030, there was a renewed global commitment to revisiting strategic investments in global health. Global surgery became an indispensable part of healthcare, necessary for progress towards universal health coverage. The scope of the problem is large. In 2010, an estimated 16.9 million lives, 32.9% of all deaths worldwide, were lost from conditions needing surgical care. That surpasses death from HIV/AIDS, TB, and malaria combined. Each year, at least 77.2 million disability-adjusted life years could be averted by basic life-saving surgical care. As with so many global health challenges, the burden of untreated surgical conditions falls heaviest on individuals in low and middle income countries. And while one procedure is done per 10 people for people in high income countries, globally, 5 billion people don't have access to safe, affordable surgical and anesthesia care. $143 million additional surgical procedures are needed in low and middle income countries each year to save lives and prevent disability. Of the 313 million procedures undertaken worldwide each year, only 6% occur in low income countries where over a third of the world's population lives. 33 million individuals face catastrophic health expenditure due to surgical care. And without urgent and accelerated investment in surgical scale-up, low and middle income countries will continue to have losses in economic productivity, estimated cumulatively at $12.3 trillion between 2015 and 2030. In 2011, the death total for the world was almost 55 million. 45 million of these deaths occurred in low and middle income countries. 23 million of these deaths could have been averted or prevented. Between 4.7 to 16.9 million of these deaths could have been averted by surgery, although this number is likely an underestimate as not all common surgical conditions are listed as distinct entities in the global health mortality estimates. And at least 1.5 million of these deaths could have been averted by essential surgery. This map is showing the number of all health professionals per 10 million population. The lowest number of health professionals are in South Asia and parts of Africa. This map is showing the critical shortage of healthcare providers globally. In the 2006 World Health Report, critical shortage countries were defined as those with less than 2.28 doctors, nurses, and midwives per 1,000 population. The regions with critical shortages in providers are in South Asia and parts of Africa. In comparison, in the US, nurses and midwives alone add to 15.7 per 1,000 population, and US doctors alone are at 2.9 per 1,000 population. This map is showing the proportion of the population without access to safe, affordable surgery and anesthesia care by country. Unmet need is greatest in sub-Saharan Africa and South Asia. Contrast the last slide with this figure showing the number of surgical procedures by country per 100,000 people. In the US and Canada, over 10,000 procedures occur annually, which is 1 procedure per 10 people annually. In South Asia and in many countries of sub-Saharan Africa, as few as 50 procedures occur per 100,000 people, which is approximately 1 procedure per 2,000 people annually. And And now when we look at the countries based on gross national income per capita, we see the pattern continues. The countries with the critical healthcare provider shortages are the same countries with the lowest access to surgery, the same countries with the lowest number of surgical procedures per capita, and here on this map are the same countries which are ranking low and low middle income, with the majority being in South Asia and parts of Africa. Now, surgical procedures can be completed in a range of facilities. The level of facilities are based on the resources and subspecialty care provided. Community facility has primary outpatient capabilities, like minor procedures not requiring inpatient monitoring that can be done under local anesthetic. Procedures like dental care, simple incision and drainages, and normal vaginal deliveries. Some of these facilities have capabilities for overnight observation. First level hospitals imply facilities staffed by providers with surgical expertise, with fairly well-developed surgical capabilities and approximately 50 to 250 beds. These facilities have lab and imaging services for general analysis, but no specialized pathology or radiology. Referral hospitals, also considered second and third level hospitals, are facilities that have advanced or subspecialized expertise for treatment of surgical conditions, like obstetric fistula. These hospitals have a higher number of beds and have specialized diagnostic capabilities. Within the limitations that are inherent in defining surgical conditions, experts have tried to outline the essential surgical conditions and procedures or surgical care needed to treat them. Essential surgical conditions can be defined as those that can be successfully treated by a surgical procedure or other surgical care that is cost-effective and feasible to promote globally, those that have a large health burden, or those that are primarily or extensively treated by surgical procedures, such as urgent or emergent conditions like acute abdomens, open long bone fractures, and medically indicated cesarean deliveries. More specifically, here's a list of surgical procedures based on level of burden, implementation feasibility, and cost effectiveness. The columns with facility types indicate the lowest level of health system in which care could be provided in a low and middle income country setting. Red font implies an urgent or emergent condition or procedure. Now, I'm mainly showing outpatient and OBGYN procedures here, but I've attached supplemental slides with all essential surgical procedures, which will be available for personal viewing. Health systems in different countries are structured differently, and what might be suitable at various facilities will differ. Regardless, safe anesthesia and perioperative care are necessary components of all of these procedures. Now, how can we measure the true burden of disease, of essential surgical disease? Well, we can look at the total deaths or mortality rates, but experts continue to reinforce the use of the disability adjusted life years, or DALY. The DALY is a summary measure of population health that sums up fatal burden and non-fatal burden into a single index. We look at years of life lost, or YLLs, and years lived with disability, or YLDs. Mortality just doesn't give a complete picture of burden of disease. The benefit of using DALYs is that the burden of diseases that cause premature death but little disability, like drowning or measles, can be compared to that of diseases that don't cause death but do cause disability, like cataracts causing blindness. So DALY is increasingly used as a factor to inform resource allocation. So when we're assessing surgical burden by mortality versus DALY, we note that essential surgical conditions contribute to at least 4.7 million deaths in low and middle income countries, which is 10.4% of all deaths in low and middle income countries. But in comparison, it's estimated that surgical conditions contribute to 340 million DALYs, which is 14.2% of the total global burden of disease and death, or DALY, from these essential surgical conditions. Now, when we specifically look at DALYs for major obstetric complications worldwide for 2010, the collective disability for all measured maternal disorders reached 16 million DALYs. Of this number, 3.3 million DALYs were attributed to maternal hemorrhage, 1.8 million to complications of obstetric labor, 1.3 million to maternal sepsis, and 2.1 million related to abortion. These numbers are indicative of the tremendous morbidity associated with surgically preventable obstetric complications that can be targeted worldwide. Now, as you can see, when you compare 1990 to 2010 data, there have been dramatic improvements in the past 20 years. However, obstructed labor has lagged behind the major maternal disorders. This lag is partly due to challenges in the treatment of this condition. Simply having access to safe and timely cesarean delivery can prevent the sequelae of obstructed labor. This simple procedure has been more difficult to implement in low and middle income countries, in large part because of the associated upfront systems costs and provider availability. If we want to observe just maternal mortality, keeping in mind that this figure does not account for any permanent disability from obstetric conditions, we see that in 2000, total maternal mortality was 421,000. By 2017, worldwide maternal mortality had decreased significantly to 279,000. The maternal mortality ratio, defined as total maternal deaths annually during pregnancy, childbirth, or within 42 days of termination, per 100,000 live births, improved from 321 in 2000 to 207 in 2011. Overall success has been attributed to improvements from the Millennium Development Goals in the total fertility rate, per capita income, maternal education level, and presence of skilled birth attendants. Why surgically treatable conditions are not more widely appreciated as a critical public health problem continues to be the question. Although the answer is complex, it is in part related to the misconception that surgical care is too costly. 14.2% of the global burden of disease measured in disability-adjusted life years could be treated with surgery. This figure summarizes the cost effectiveness of surgical interventions in low and middle income countries. The research surrounding global disease burden and surgical costs has expanded and consistently documented that essential surgical services rank among healthcare's most cost-effective interventions. For example, cleft lip repair is $10 per DALY averted, $10 to $110 per DALY averted. Cataract surgery is $50 per DALY averted, and emergency cesarean delivery is $15 to $380 per DALY averted. Many of the widely disseminated public health measures are of similar cost effectiveness or not as cost effective. For example, while measles immunization is $30 per DALY averted, HIV antiretroviral therapy is $900 per DALY averted. Many people with acute surgical conditions die in the pre-hospital setting. Improving first aid skills of layperson first responders is less than $10 per DALY averted, and basic ambulance services are $300 per DALY averted. It's estimated that it would cost low-income countries approximately $3 to $5 billion annually to scale up the delivery of the essential surgery package in first-level hospitals, those essential surgical conditions that I had shown earlier. Now, $3 to $5 billion for low-income countries annually sounds astronomical, but disease affects the country's labor supply and capital stock, which in turn are related to aggregate economic output or gross domestic product over time. We're linking disease to economic growth. The value of lost output secondary to surgical conditions was estimated for 128 countries between 2015 to 2030 for a cumulative loss to the global economy of $12.3 trillion, or 1.3% of economic output. By 2030, surgical conditions in low and middle income countries could consume as much as 2% of these countries' projected GDP. These numbers make the billions of dollars needed in investment pale in comparison. So we understand the scope of the problem, the associated cost, and the cost effectiveness. But if we want to appropriately invest resources into the global burden of surgical disease, then we need to understand what barriers are at the level of the individual and community. Delays in care have been categorized in 3 phases. First, a delay in deciding to seek care. Second, a travel delay or a delay in reaching adequate health facilities. And third, a delay in receiving adequate, appropriate, timely care once at the health facility. Under the larger category of 3 phases of delay, the barriers which individuals face can generally be divided into 3 dimensions: acceptability, affordability, and availability. The first delay occurs when patients often wait to seek healthcare because financial and geographic restrictions, cultural beliefs, low health literacy, a history of being disconnected from formal health systems, and low awareness of available services or low confidence in those services. The second delay occurs when hospitals with surgical capacity are scarce, meaning the nearest facility can be hours to days away, depending on mode of transportation, and few patients have access to private vehicles, ambulance systems are rare, and the availability of public transportation can vary. The third delay occurs due to hospital efficiency, personnel availability, and the hospital's inability to guarantee treatment. Resources such as stable electricity, water, oxygen, and dedicated emergency care are needed for surgical care. Now, the figures here are from a study aimed at using the 3 delays framework to measure the actual delays at each stage faced by patients receiving bellwether procedures in low and middle income countries. Specifically, this data is from Timor-Leste. Bellwether procedures are any procedure involving emergency laparotomy, cesarean delivery, or treatment of open long bone fracture. The ability to perform the 3 bellwether procedures in 2 hours is closely associated with being able to provide all essential obstetric, general, basic, emergency, and orthopedic procedure care. Overall, the total mean time delay from symptom onset to receipt of essential surgical care was 32.2 hours, irrespective of the bellwether procedure. The mean delay time across bellwether procedures was greatest for the first delay at 20.9 hours. Irrespective of the bellwether procedure, patients waited an average of 2.75 hours to be seen by a surgeon after presenting to the hospital emergency department. And after being assessed by the surgeon, the decision to operate was actually quick at approximately 20 minutes, but there were subsequent delays in getting to the OR of 4.2 hours. Factors contributing to the delay include fasting status, OR access, awaiting imaging, and preoperative blood transfusion. This study shows an example of the considerable delay in surgical care in low and middle income countries. In terms of the first delay, when each type of procedure is evaluated, we can see the considerable delay in seeking care when patients experience acute abdominal pain or in labor. But there's almost no delay in seeking care if a patient experiences an open long bone fracture. This finding with patients with an open long bone fracture preparing to go straight to the hospital suggests that better education as to what to do in the event of acute abdominal pain or protracted labor might be successful in shortening the first delay in care. This is a little picture break. This is the group from the Multidisciplinary Fundamentals of Global Health course last year. And speaking of multidisciplinary, the goals of achieving a functional health system and a functional surgical system aren't separate. So now we'll go over major strategies for forward progress in global surgery. Of course, pre-hospital primary care centers and rapid response ambulances would be great, but the first focus should be on a more immediate approach with interventions that engage the community and existing providers. Surgical teams should engage all members of the surgical ecosystem, including informal providers and community health workers, particularly in areas without formal healthcare facilities. Culturally appropriate outreach to the community and existing health networks is essential to promote health system use. And like the study we just discussed, perhaps better education as to what to do in the event of acute abdominal pain or protracted labor might be successful in shortening the first delay in care. A comparative model is integration of traditional birth attendants into the maternal health system to refer critical cases to first-level hospitals. Community health workers have already been effectively used in many large-scale programs, especially in Partners in Health, with documented improvements in health outcomes. A Bangladeshi NGO has devised a low-cost referral system for obstetric care, which uses community health workers and traditional birth attendants. They give them mobile technology that enables community health workers to identify complicated labors and coordinate reliable, timely transportation to a hospital. Community participation is already the default for emergency transportation in many low-resource settings, and these ties should be strengthened while more formal systems are developed. In Ghana, truck drivers who brought trauma victims to the hospital were compensated through a fund established for this reason. And in Uganda, community-based trauma response programs have trained individuals who are likely to be near accident scenes, like taxi drivers or city police, in basic first response techniques. Lastly, when geographic challenges are immense, an alternative approach is to bring care to the patient. An Ecuadorian NGO founded in 1990 uses a 7-meter truck with a mounted operating room to take surgical and anesthesia care to patients in the country's mountainous regions. Similar approaches are used for radiology screening. Upon reaching the hospital, patients should have a reasonable guarantee of treatment. First-level hospitals should serve as the core delivery site for surgical care, And if sufficiently equipped and staffed, it should also be able to provide about 80 to 90% of surgical procedures. This is about more than just how much suture there is or how many scalpels there are. Surgical care needs to be integrated into the national health systems for supplies to be available. That requires discussion between policymakers, donors, health system managers, and providers in low and middle income countries about funding allocation, centralized purchasing agreements, and supply chain management. That will allow facilities to order supplies per local needs. We also need to look at providers. Providers at first level hospitals often feel isolated and have few opportunities for interprofessional interaction. Improved network connectivity with tertiary hospitals will allow for collaborations. Examples are system-wide morbidity and mortality conferences hosted by tertiary centers over a mobile link to connect remote first-level hospital staff into a forum for multilateral learning. A collaborative approach in India between a tertiary center and rural hospitals has been fostered by the Christian Medical College. They send surgical graduates to practice in rural communities. The grads are paired with colleagues at the tertiary center to be available by phone for case support and referrals. And finally, connections with tertiary hospitals can also serve as a referral system for complex radiology, pathology, and other services that aren't available at first level hospitals. Incision and drainage capabilities seem to exist in 75% of first level facilities, and general practitioners and non-physician clinicians without significant surgical training perform the majority of these procedures. But lack of training and supplies is the most common reason cited when patients are referred to higher level facilities for incision and drainage from first level facilities. This figure is from a 2012 study out of Mongolia that coordinated a 2-year-long countrywide initiative to strengthen surgical services at first level hospitals in Mongolia. At the end of 2 years, there were significantly increased capabilities across the board, but most evident inability to perform wound debridement, wound suturing, and incision and drainage of abscesses. Another method forward is process standardization. Process standardization can be a low-cost driver of efficiency, quality, and safety. One example is WHO's surgical safety checklist, which showed that adverse events in low resource settings could be reduced through a simple method for communication. Most hospitals can benefit from process standardization, and organizations with relevant guidelines for low resource settings should make them publicly available. This can be done through registries hosted by the WHO or other international collaborators. Healthcare managers can work with clinicians to identify relevant protocols and help adoption according to local context. Management guidelines do need to be contextually relevant. What might work in high-income contexts may present a challenge in the low resource setting, and providers in such settings can feel vulnerable when resource constraints force clinical decisions that are different from contextually irrelevant but published protocols. Surgeons in low and middle income countries have workarounds to infrastructure deficits, like rainwater collection reservoirs and use of solar power. But official investments still need to be directed towards the basic needs that aim for a well-distributed shared delivery infrastructure, because resource needs change with time and between contexts. Partially, it's hard because it's hard to agree on what constitutes safe or quality surgery. Adverse events exist even in high resource systems, and blindly pursuing high-income country options can be dangerous. Many life-saving practices in low resource settings can be mischaracterized as unsafe. For example, in some rural Indian first level hospitals, pressure cookers are used for equipment sterilization. Otherwise, reliable supply chains are crucial. Shortages are often due to inadequate information and poor management. These issues can be countered with upfront investment and following the standards of supply chain. Streamlining of procurement decisions is also important. For example, restriction of suture orders or operating with equipment to a standardized set according to clinical consensus instead of individual surgeon preference can also yield availability and cost saving. Moving on to technology in global surgery, again, we need to have context-specific designs for low resource settings that minimizes reliance on consumables and the need for maintenance and repair. For example, all donated equipment should be accompanied by long-term maintenance contracts or should be replaced by funds for local investments. Another thing we see is that the lack of technically trained staff is a significant barrier to technology development and adoption. This is often attributed to brain drain, where technical skills developed to disseminate a technology are lost as people move out of areas of need to more attractive environments. One strategy to overcome this challenge is to develop bilateral international training partnerships and have incentives for skilled workers to stay. Additionally, organizations should follow the WHO guidelines for each stage of medical tech development and evaluation, including device regulations, needs assessment, human resources, procurement, and maintenance. Interestingly, laparoscopy is the preferred technique for many conditions due to improved short-term clinical outcomes. These benefits are even more pronounced in low and middle income countries where access to follow-up care is limited, and there is a greater pressure to return to work to prevent worsening poverty. Laparoscopy also provides a cost-effective diagnostic tool where radiologic facilities are limited and may reduce negative laparotomy rates. The limiting factor is that laparoscopy requires advanced providers, equipment, and infrastructure. Even with these challenges, laparoscopy has been implemented successfully in low-resource settings with complication rates similar to those in high-income countries. A recent system review describes several adaptive strategies to enhance the adoption of laparoscopy in low and middle-income countries. These include infrastructure innovations like soft drink companies providing carbon dioxide, using sunlight as a light source, and implementing low-cost box trainers for surgical training. Another advancement was due to the WHO mandating pulse oximetry on the safe surgery checklist, which is the only piece of equipment required. Experts had highlighted the global lack of pulse oximetry as a significant unmet global health need in surgery. The need was met by the NGO Lifebox that developed a pulse oximeter designed specifically for the needs of low resource settings. The project has provided over 15,000 pulse oximeters to hospitals in 100 countries. Recently, laparoscopic surgery was introduced in rural Mongolia by building high-volume bilateral training teams and adapting to local community needs to build sustainable laparoscopic devices. The availability of low-cost, high-quality equipment with minimal maintenance requirements was key to successful implementation. To avoid the need for carbon dioxide insufflation, abdominal wall lift devices have been developed to facilitate gas insufflationless laparoscopic surgery, called GILS. Using this technique, a range of laparoscopic abdominal and gynecologic procedures can be performed safely under spinal anesthesia. GILS also negates the need for specialist laparoscopic instruments and trocars, and modified open instruments can be used to perform single incision surgery in rural settings. Workforce shortages at first-level hospitals make it unlikely to have a general surgeon, orthopedist, obstetrician, and anesthetist available. So first-level hospital providers are forced to command a broad skill set. For example, a family medicine specialty training program in Lesotho run by Boston Health Alliance includes surgical skills and emergency obstetrics care. However, working as a multi-specialist in a rural setting can be personally and professionally taxing. Imagine being away from family and friends, working in remote areas and poorly equipped hospitals, treating high acuity patients with limited resources, and with few opportunities for professional development. While surgical capacity in low and middle income countries grows, NGOs can play an important part in care delivery. When using an approach consistent with the local needs and culture, NGOs can strengthen the system by assisting local clinicians with demand-driven international surgical support. This support could consist of long-term postings of surgical staff to high-need areas or many sequential short-term commitments that add up to a consistent, predictable presence and uninterrupted service. NGOs play an important part in the coordination of short-term interventions and support within the larger framework of long-term commitment to system strengthening. But in reality, there is a global shortage of 7.2 million healthcare providers. And as the global burden of disease evolves, a flexible workforce must be trained. One such method is task shifting. Task shifting is the rational redistribution of tasks among healthcare workforce teams from highly qualified workers to healthcare workers with shorter training and fewer qualifications. Task shifting for OB care has been supported in a FIGO committee report as a strategy to reduce maternal mortality in the setting of an extreme shortage of obstetric specialists. The reality is that training surgeons is expensive, time-consuming, and often relies on skill acquisition through a high volume of cases under supervision. In low-income countries, most rural clinics or hospitals don't have physicians, and care is provided by clinical officers with roles similar to that of nurse practitioners. The situation currently is that 85% of all cesarean deliveries in underserved or rural areas are performed by non-physician clinicians. Unfortunately, the percentage of cesareans performed overall in low-income countries is 2.2 to 2.8%, which is still far below the recommended level of 10 to 15% to prevent major obstetric complications. Overall, most studies indicate that the quality of emergency obstetric surgeries is not at risk when performed by less skilled health workers. A 2011 meta-analysis, which included studies comparing the outcomes of cesarean delivery performed by clinical officers with those performed by physicians, showed that surgeries done by non-physicians were more likely to be associated with wound infection and wound dehiscence, but no significant differences were found for perinatal or postoperative mortality. Other studies have observed that blood transfusion and surgical error rates are similar. The increase in wound infection and dehiscence rates may highlight a particular infection control training need for non-physician health workers. However, other studies assessing the clinical competence of OB care providers in Mali found that physicians had higher clinical competence scores out of 100 compared with obstetric nurses and midwives. But obstetric nurses and midwives had slightly higher scores for neonatal care compared with physicians. And in India, of the 233 skilled birth attendants assessed for their emergency obstetrics care skill, only 58% were able to make a correct clinical diagnosis. An important reported advantage of training non-physician clinicians is retention, as demonstrated in a study from Mozambique showing that unlike medical doctors who leave within 3 years, 88% of non-physician clinicians continue to work in the same hospital after 7 years. It seems that non-physician providers in these settings can gain proper manual skills, but may miss essential diagnostic accuracy due to knowledge gaps, but more research is needed. To conclude, gross global inequity exists in the burden of surgical conditions and access to surgical and anesthesia care between high-income countries and low and middle-income countries. The magnitude of burden from surgical conditions is large. 5 billion people don't have access to safe, affordable surgical care. And due to this, up to 2% of potential annual economic growth is lost in low and middle income countries. Analyses have found the scale-up of global surgery to be cost-effective and cost-saving. The 3 delays framework allows for a thorough evaluation of the barriers to care at the level of the individual, community, and site of care. And finally, even though we're still working towards a universal, sustainable surgical care, we've seen that the people and providers in low and middle income countries are resilient, and the global community is strategizing to overcome the current global burden of surgical disease. Overall, this talk touches the surface of global surgery. The goal is to build strong, resilient surgical systems that can provide consistent, high-quality care for all. I have to give a special thank you to my friends and family, my co-residents, the Global Health Track, and Dr. Karnowski, Dr. Rice, Dr. Hartenbach, and Dr. Spencer, and finally to the Department of UW-OBGYN. I thank you very much for your attention, and I look forward to any questions or comments.
Great talk, Ushma. This is Jenny Karnowski. Sorry, I have to run to the OR, but could you talk a little bit about kind of some of the ethics of like short-term surgical trips? I think that's maybe what a lot of us are used to.
That's a great question. I was wondering if I would have time to include that in the talk. So I do have a slide up. So there's a couple of ethical considerations that I was going to mention. One of them I briefly touched on was donations from high-income countries. But since you're specifically asking about short-term surgical care, the terminology we use a lot of the time is visiting volunteers. That has been a big discussion because clearly there is a need for increased and improved surgical care in low and middle income countries. But there's many barriers to providing safe and effective surgical interventions in these settings. And when visiting volunteers come and provide surgical care, there's lots of challenges with time constraints, culture, language barriers, and just incongruent expectations. So for example, I've listed here supplies and capacity. Surgical equipment is different. There might be differences in dressings. One area I was in used like cling wrap and sponges for wound vacs, and these are things that people just aren't used to. And sometimes I think volunteers also feel like they're providing subpar care, when in reality, this is just the reality of the situation and what is being done in these settings. Other problems with short-term care that most people are familiar with is that if you're just going for 2 weeks and there's not the short-term commitments set up that lead to full presence all year round, then the burden of post-operative care falls on local providers. And most of the time it's fine if it's just a simple post-op course, but if not, then the non-physician clinicians or physicians in those settings have to deal with your complications, which kind of falls under this temporary bullet I have up. The operating conditions are less ideal than what volunteers might be accustomed to. And so it's not that volunteers have lacking surgical skills, but they just truly are not equipped to provide care in these types of settings, and might actually end up providing worse care than they would be accustomed to in their own high income country setting. And then there is this idea that, you know, at the end of a trip, I've heard this many times, like, how many people did we treat? Which sounds fun, and it's always exciting to like look back on your time on the trip when you debrief, but the reality is that we're never measuring outcomes. So it's easy to say like, what's the body count is sometimes as how it's reported in literature, but we need to look at what the true outcomes are, and we can't do that with these short trips. And then finally, we're seeing unfamiliar surgical conditions. So for example, hernias might be larger than what people are used to. There might be parasites in the hernia sac. TB causes bowel obstruction. So it's just a whole different ball game. I hope that answered your question without too much. It's just a topic I'm passionate about.
That's great. You've got lots of very nice comments here in the chat. Thanks, Dr. Karnowski, for your question there. Any other questions this morning?
Ush, is there any information surrounding tubal sterilizations in low, medium countries?
Yes, that's a great question. So tubal sterilization is one of the essential surgical conditions listed on the figure I showed you, meaning it's a surgical condition that should be available and provided at first level hospitals and shouldn't be considered elective, which is obviously ACOG stand on it as well. I think I have, okay. So I don't have numbers available for you, unfortunately. I don't know if those are available or if I just didn't look hard enough, but there's a study from rural Kenya, and there's this concept of vocal local. So of course, the limiting factor in a lot of the surgery that I've talked about is resource availability. And if you can potentially get rid of the need for anesthesia and an anesthetist, then you can really increase the volume that you're doing your tubal sterilization procedures. So in this study, they use vocal local. So sorry for this extra figure with a lot of words. It's just for people to read on their own if they want to. But essentially, it's using local anesthetic and somebody just soothing the patient near their head and kind of distracting them, giving them anti-anxiety techniques to just complete the tubal sterilization. So they compared doing vocal local plus local anesthetic as the intervention to doing vocal local, the lidocaine and anesthesia, and they found that the pain scores were the same and the satisfaction scores were the same, and that 96% of people would recommend this to their would recommend this procedure. And the study was done with over 800 women. So I just think it's ingenious, the things We do. I hope that answers your question.
Thanks, Ushma.
Thanks, Ush.
Great. Well, really great presentation this morning. Thank you, Dr. Patel, for sharing this passion of yours with us. And I think we'll wrap up here. If anyone has any further questions, I'm sure Dr. Patel will be happy to chat with you in the OR or on the labor floor. So thank you, and everyone enjoy their day today.